Welcome to our monthly webinar series hosted by the Office of Integrated Healthcare Research and Policy in the Department of Family Medicine at the University of Colorado School of Medicine. Let me begin by telling you a bit about our sponsor and partners. This webinar series is sponsored by the California Mental Health Services Authority Integrated Behavioral Health Project. CalMESA is an organization of county governments working to improve mental health outcomes for individuals, families, and communities. Prevention and early intervention programs implemented by CalMESA are funded by counties through the voter-approved Proposition 63, the Mental Health Services Act. Prop 63 provides the funding and framework needed to expand mental health services to previously underserved populations in all of California's diverse communities. The Agency for Healthcare Research and Quality, Academy for Integrating Behavioral Health and Primary Care, functions as a coordinating center and national resource for people committed to delivering comprehensive integrated healthcare. The Academy focuses on integrating behavioral healthcare into primary care practices and promotes a collaborative environment that fosters dialogue among leaders and other stakeholders. For more information, you can visit integrationacademy.ahrq.gov. The Collaborative Family Healthcare Association is a nonprofit, member-driven, collaborative organization in existence since 1995. CFHA promotes a comprehensive and cost-effective model of healthcare delivery that integrates mind and body, individuals and family, patients, providers, and communities. The Advancing Care Together project at the University of Colorado Denver Department of Family Medicine is a 4-year program aimed to discover practical models to integrate mental health, substance use, and primary care services. The program is funded by the Colorado Health Foundation and funds 11 demonstration projects which have been organized as a set of diverse comparative case studies and will be linked to support cross-project learning. Before I introduce our presenters for today, I want to quickly go over a few housekeeping items for using GoToWebinar. So on the left-hand side of your screen, you'll see the control window where the PowerPoint is appearing, and then on the right-hand side is the GoToWebinar control panel where you can listen through your computer's microphone and speaker or call in using the telephone. Beneath there is a question box. At the end of the webinar, we'll have 10 or 15 minutes for questions, and you can type your questions into the box, and I can read them out loud for our presenters. If you choose to raise your hand and ask the question verbally through the phone, there's a little hand icon that you'll just click. Also, the webinar is being recorded and will be posted on our YouTube channel, which is listed on the PowerPoint. So today we are pleased to bring you Dr. Amy English and Ms. Kristen Sutter. Dr. English is a family physician practicing in Denver, Colorado. She is currently completing a practice transformation fellowship through the University of Colorado Denver Department of Family Medicine. She's interested in patient engagement and improving complex patient care, both as they relate to practice transformation and residency education. Kristen Sutter is a quality improvement coach and community liaison for the High Plains Research Network and has worked with primary care clinics and communities in 9 counties of northeastern Colorado to implement, maintain, and evaluate research studies. She has contributed to projects on colon cancer, asthma, home blood pressure management, childhood obesity, behavioral health, and cancer survivorship. She's currently working as a quality improvement coach for clinics in eastern Colorado who will be doing practice transformation work through a variety of different initiatives. Yesterday, I sent an email with handouts that the presenters provided. If you registered for the webinar this morning, I will send those out to you afterwards. So thank you both. And Amy, I'm going to pass the screen control to you.
Well, good afternoon, everyone. I'm just going to start quickly. My name is Kristen Sutter, and as Emma mentioned, I'm a quality improvement coach for the High Plains Research Network. I work with small rural practices in eastern Colorado, and today I'm going to be sharing with you some of my experiences and lessons learned in helping those practices as they tried to create and sustain patient advisory councils in their clinic settings.
And I'm Amy English. I am, as Emma said, doing a practice transformation fellowship. As of formerly as a family medicine resident, I started becoming involved in a patient advisory board that was started at my residency clinic about 2 years ago. And as I transitioned into my fellowship role in this last year, I have started facilitating that patient advisory board and can speak from our clinic's perspective, having done this for a little while. I can tell you a lot about a lot of wonderful things that we've learned, and then also some road bumps we've stumbled on along the way. So with that, we'll get started. So just quickly, our goals for today. We hope to give you some tools, some nuts and bolts about starting a patient advisory board, and offer you some resources so that you can feel like you could hit the ground running after you leave this webinar. Chris and I are going to hope to share some of our personal experiences working with our clinics in starting patient advisory boards. And then we'd like to address concerns we've both heard on the part of other providers or medical staff about starting an advisory board, and sort of identify whether those concerns are things that we see happening or things that we hear about a lot. But before we start, we wanted to kick off with a poll to find out how many of you are engaged in this process or thinking about the process, just kind of get a sense of where you are all at.
So please, a poll should appear on your screen, and please click the answer most appropriate for where you're at with patient advisory councils. Okay, thank you. I'm going to close the poll.
So it looks like we have 21% that this is the first that you're really starting to learn about patient advisory councils. 29% have started learning but haven't really thought about developing your own, and 36% of you have started putting it together but haven't met yet.
Great. Well, that sounds like a great place to start. Okay, so let's start by talking about what a patient advisory group is. There's a lot of words here, but in general, it's a group of usually very engaged patients who meet on a somewhat regular basis with a shared mission, which can take various shapes, and we'll get into that a little bit later. But in general, they tend to represent the patient voice in giving some element of feedback to the clinic. And so beyond what they are is something beyond a patient experience survey, which is an individual patient voice, but rather kind of a group sharing of those patient voices, which allow group ideas to emerge, giving patient feedback a extra dimension beyond what you can get in a patient survey. They also provide opportunities for providers and medical staff and patients to kind of develop a mutual experience in which both sides kind of see a little bit more of what each other's day-to-day is like, or why certain clinic operations are the way they are, and also can influence and shape future directions the clinic may choose to take. Now I'm going to turn it over here to Kristen.
We know that establishing a successful patient advisory council, it really takes quite a bit of planning and thought before you even get to where you start meeting with the patients. And so that can be a little bit intimidating to think about all of these things that need to be planned out and prepared for. So we really wanted to try to give you some of these key first steps so that you can, as Amy said, hit the ground running and get this sort of thing started in your facility. One of the first things you can consider when you're starting to form your patient advisory council is looking at doing a pilot focus group. There's a lot of clinics that maybe they start focusing on a diabetes-specific project, and they bring in a handful of patients to give some feedback on a specific focus group topic. This is a nice way to kind of get everybody's feet wet. So you get a chance to work with patients, the patients get a chance to feel out this process. And a lot of times you'll start to find the patients that are really interested in this type of engagement, and maybe some of those that aren't, and learn how you want that process to work. I honestly have not had any of the practices that I've worked with start through a focus group. Most of them have just hit the ground running and just pulled their group together, but I do think it would be a nice way to kind of ease everybody into the process. So as you prepare to meet with your patient advisory council, one of the things you really want to look at is establishing a clear mission. So as a practice, you're going to think about what you'd really like to accomplish in the next 3 months, 6 months, or a year, and why is this patient input important to your practice, and how are you going to measure your success as you go through this? All of those things will help you decide what your mission is for this patient advisory group. But I just like to point out how important it is, though, as you form this mission, to go into your first meeting with a framework and present it to your patients. But your patients really do need to have a strong role in shaping what the structure of your advisory council is, and the agenda. So you're going to have a mission, and your patients are going to help you establish and solidify that mission as you move through. Having bylaws, the bylaws really help you lay out your terms for everyone involved. So what's it going to look like to be a patient advisory council member? How long are you going to serve? What are the expectations? What sort of boundaries do we need to have for confidentiality for everyone involved? And so in most of the practices that I've worked with, we've started out with bylaws that other patient advisory councils have used as sort of a general framework. And then with the help of the patients, the group establishes collaborative bylaws that work for everyone. Engaged leadership is essential. Change just isn't going to happen without key leadership being involved, and that just leads to frustration for everyone involved. Helping the clinic quality improvement team to appreciate patient engagement. I have very often seen this just be a natural process. A lot of times the quality improvement team really very quickly sees the value that patients can bring to their work. Patients really make all of the work that we're doing seem more relevant, and we can see what is important to the people that we're trying to serve. It's important to think about the timing of patient feedback and quality improvement projects. Historically, a lot of the practices that I worked with, when they did seek out patient feedback, it was late in the process. Maybe they'd already established materials or handouts and then sought patient involvement. And this really brings patients in from the very beginning and throughout the process. Compensation, this varies throughout, and a lot of times patients aren't necessarily driven by compensation, but it's certainly nice if you're able to at least provide some food or some sort of bonus for patients attending. Meeting logistics. When and where are you going to meet? This can be difficult when you're trying to get a group of people with busy schedules to come up with a consensus, but you really want to try to work what's best for everyone. So a lot of times I see lunch meetings or groups meeting right after work. A lot of times it's in the clinic if there's an appropriate meeting facility. Other times they're seeking out other community venues where they can all meet. How often? Generally, the IAC practices start out on a quarterly basis. I'm starting to see a movement, though, towards a lot more monthly meetings as the patients get involved and they get excited, and the clinic starts to really take that feedback and use it regularly. There's a lot more push to meet more often. I think you'll see throughout this that it's important to look at this as it works for your individual clinic, and how it meets your needs and your patient's needs. It's important to think about who's going to facilitate the meeting. I really think this is key to the success of your group. You want to have someone who's able to open up discussion for the whole group, and really encourage people to give feedback. And they also need to know how to keep things moving so we don't get snagged on one topic or headed off in the wrong directions, but keeps things moving and keeps the group working together. And that's really a skill and can be a challenge when you get started. Who's going to be in charge of taking minutes and sending the reminders and recaps? This can be someone on the clinic side, or it can be a patient. I have seen where patients have welcomed a role in some of these activities, maybe not right away, but through time. But it is important to have a designated person responsible for those things. There's also, as I mentioned, there gets to be a lot of projects, and once you start having this input, a lot of times practices will find themselves needing some input from patients outside just the regular scheduled meeting times. So you might want to look at how you're going to structure that, whether that would be through, is it okay to contact by email or by phone outside of those regularly scheduled meeting times?
Mm-hmm. Kristen, the only thing I would add too is that I think how often ties back into the mission of your patient advisory board. Our patient advisory board meets monthly, and we tend to spend a lot of time giving feedback on QI projects that are happening within the clinic. As a pretty large residency clinic with 45 providers, there's often a lot of QI projects popping up, and so monthly seems to fit that goal. If a group was more project-based, they may want to meet quarterly and have little project-related meetings in between those quarterly meetings to help keep projects moving along. So you kind of have to think back to what you're defining the mission as and figure out the frequency and the structure that both works with that.
That's a great point, and being flexible to move with that as you need to.
Mm-hmm.
Determining the makeup of your patient advisory council, the number of patients, these are things that get discussed a lot, and there's a lot of different standpoints on this. You'll often hear 8 to 10 patients as the general recommendation for the number of people on an advisory council. Which clinic members should attend? There's a lot of discussion that you may not want to have too many clinic members or outnumber your patients with clinic members. I've honestly seen a number of different makeups on advisory boards. In some cases, there's 1 or 2 staff members to a large number of patients, or other times there's been a good mix, half and half of both. And I think both cases have worked. I think it's important when you think about which clinic members attend, though, that you make sure that there is a person in a leadership and a decision-making role who's attending these meetings, because it's very common for things to come up that need action or decisions, and having that sort of a person at these meetings helps you to move more quickly through the process. You also want to look at who your clinic serves to make sure you have good representation from your patients. So you want to think about things like the age of the patients you're serving, race, gender, family structure, and those sort of things. So as you start to look at how you're going to find patients to serve on your council, there's a number of different ways that you can identify patients. One of the most common ways that I've seen is really through provider suggestions. They think about patients that they have who might be interested and really valuable contributors to this sort of an activity. You can pull them from a focus group, as I mentioned earlier. There's a lot of clinics that are looking at waiting room sign-up. I had a practice that started out initially with provider suggestions to establish their council, and they had a group of about 8, but they went to a 2-year term. And so they're looking at having a number of patients who will come off in the next year, and so they have established a waiting room sign-up sheet. And that way they have a list of patients who are interested, and they're able to pull off of that list as patient advisory council members move off the board. You can send out emails or letters to your patients. A lot of times, if you have involvement from community outreach workers or community leaders, might be able to point you to activated community members who would be good in this role. I had, I'm sorry.
Sorry.
I had one clinic that started out with, they weren't really sure how to come up with a good group of patients. And so they identified as many as 30 patients that they were going to invite to their initial meeting. And so they sent out letters and invited this large group of patients, and they brought them all in, and they explained the process and the expectations. And at the end of that meeting, they allowed the patients to really express their interest level in participating in the advisory council. And through that, they weeded out about half of the patients that many of them were interested, but the timing wasn't right. And so there'll be patients that they'll maybe look at contacting down the road as fill-in members in later years, as well as people who just didn't have a whole lot of interest, and they came up with a good group of about 10 people through that process that allowed them to establish their initial group.
I just wanted to add too, I would just consider how your method may contribute to attrition. So if you're going to collaboratively set up your meeting time with those chosen, then you're less likely to have conflicts. But if you, you're more likely to have conflicts, as people who've suggested they're interested may not be able to commit to, we may not all be able to find a shared time, etc. So I do think about an 8 to 10 member group seems to function well, but in our experience, we started with about 12, and then slowly over about a 9-month period weaned down to about 8, and then probably over the last 2 years have transitioned down to about 6 and had to regular members and had to recruit again. And recruitment is it requires a decent amount of time and effort on the part of one or more medical staff folks. So just kind of think about your initial start number as it may relate to a few people kind of deciding this isn't quite meeting their expectations over time and leaving the group.
And there are a number of qualities that you really want to think about as you're looking at patients to join an advisory council. This was probably one of the key stressors for the practices that I've been working with as they establish their council is finding the right people who can see the big picture, and they can listen to other people's opinions that might be conflicting with their own, but be able to take them in and work collaboratively in spite of those differences. They were also worried about, finding patients who kind of got stuck on their own personal agenda, or whether it's a political agenda or whatever that is. So kind of looking at that as you select your members, and if they're going to have a sense of humor to handle some of the challenges and the struggles that are going to come along, and to connect with other people. They're going to have to be able to learn to step outside their own comfort zone, maybe talk about things they're not as comfortable talking about or listening to. And one of them that has turned out to be really key is that they're willing to share their opinions and thoughts. One of the clinics that was establishing their advisory council was very nervous about starting this process and wanted to make sure they started with a really good group to help them ease into the process. And so they picked 8 very friendly, very cooperative patients. And what they found happened was that now they're frustrated because they're not getting a lot of feedback. They're not getting a lot of suggestions for improvement because their patients are almost too agreeable. So they really needed to, they're starting to look now for some patients who will be willing to share more of those thoughts and opinions. Another thing to look at is inviting friends and family members to serve together. We have a couple of advisory councils where spouses serve together. They like to come, they enjoy doing it together, and sometimes it helps with their attendance even to have people work as couples. A lot of times you can also get that patient caregiver experience if you have a couple come together and one of them has a chronic condition and the spouse is the caregiver, and they can bring each of those perspectives when they come.
From my experience, I'm not sure. Our recruitment process involved provider suggestions, and I don't know if it's the result of that method or what, but our board is largely made up of patients who've had a very long standing relationship with their primary care doctor, and a lot of them have actually worked in healthcare fields. One is a former nurse, one worked for an insurance company for a long time, another is actively doing surveys about people's perceptions of the quality of their care. And I have to say that has been a wonderful way for people to be able to speak in broader terms about healthcare and quality of care.
So some of the common reasons that we hear from clinics for not starting an advisory council is this fear that we're going to get these suggestions from our patients, and what if we can't do what they're asking? You know, we don't want to let them down. And it's a pretty legitimate fear and a concern, as many of us, this is a new process for us. One of the first clinics that I worked with that started an advisory council, they had their first meeting, and when they went in, the patient said, we would really like to see some changes to your waiting room. We can hear every little bit of the conversation that's happening at the front desk. When you call to set me up for labs, everybody in the waiting room can hear what you're calling for. We'd really like it if you could add a wall right here so that the waiting room isn't so close to the check-in and the check-out. And they came back from the meeting and they were just a nervous wreck because they didn't have the budget for a brick and mortar improvement in their facility at that point in time, and so it was very scary and intimidating. And as they talked through it, they figured out some solutions to the problem without having to add a wall to their waiting room. They added some music and they moved chairs to a different area in the waiting room so that they weren't facing the check-in. And the Patient Advisory Council ended up being very pleased with the changes. It took a little bit of creativity and some outside-the-box thinking for the clinic staff, but they were able to address those suggestions without doing it exactly as the patients had suggested. But that can be a little bit stressful as you're getting started. Also, not enough time. We've mentioned a lot of things that you need to think about and plan for and keep up as you're going through this process. And it is important that you can dedicate some staff to work on this, and they're able to allow the time to set agendas and take care of minutes and communicating with advisory council members. If you don't have resources for compensation, and that's a very real concern for a lot of clinics. Or there's the fear that the patient input might just slow the process down. Let's just do the project and then we'll ask them later. But I would argue that a lot of times that can work the very opposite way. A lot of times if you've done all the work and then ask for patient suggestion, you might be a little disappointed and frustrated when you find out that the language or the topic aren't relevant or important or make sense to the patients that you're showing, at which point you have to start over. So, but it is a fear that we encounter often.
Mm-hmm. I think, that first bullet point, that fear that suggestions won't be able to be implemented. I think a lot of, on the medical side of things, we have this fear that we're going to have this us versus them moment. And in reality, I think what I've experienced is those are really the moments where we gain mutual appreciation for each other's roles. So if a patient suggests something, I usually don't respond. It's usually not something that I truly feel the response is you're wrong. It's actually, I really agree with that, but this is why this has been so hard to change, and now we see eye to eye. And so those actually are kind of opportunities, I think, for growth and collaboration and kind of strengthening the relationships on the board. And then the other thing I would just caution is it requires a little bit of clinic culture change sometimes to get patient input at the onset of QI projects. But when that piece is lacking, when the patients are brought in at the end, the cost to that is it can oftentimes for the patient sort of feel like they're kind of the token patient on this. You know, the project's all set to go, and now they just have to give it their stamp of approval. There's not a lot of wiggle room for changes to actually occur at that point. And so sometimes it can kind of feel a little not relevant for them in those, if that's kind of the process that you're seeing happen frequently.
I've talked about many of the lessons learned, but one of the key ones I'm going to stress again is just that there's really not a one-size-fits-all way to do this process. And a lot of times the way you start may not be the way you move along. You might start with 12 members and find it's too many. Or you may not involve providers in your first couple meetings and then figure out that's a really important thing and you're going to change that. And that's okay. You're going to be flexible throughout this process and try to do what works for your clinic. Another key lesson that I've come to see, and I think this goes to the clinic culture Amy was just discussing, but you need to find a way to get communication back to your clinic staff about what's happening at these patient advisory council meetings. I've seen a lot of times where maybe the quality improvement team is involved directly with the advisory council, but it doesn't get shared to the rest of the clinic, and they don't understand this important process and the culture change that's starting to happen because it just hasn't been communicated back to them. So having some sort of a process to involve all of your clinic members in this relationship is important, as well as just working on that group mission from the very beginning to help define everything from your recruitment method to your long-term plan.
Yeah, and just to kind of illustrate a few of those points, when we started we would meet right before a clinic-wide QI meeting. And so we would have the separate patient advisory board and then the QI meeting. Part of that was great because we could sort of debrief before the QI meeting happened, talk about some of the language they may hear, sort of ready, kind of like a mini boot camp in preparation for what you're going to be hearing, because a lot of times we'd be throwing out PCMH lingo in that QI meeting without stopping for a second to define any of it, and patients were feeling lost. The flip side was that it just happened that our clinic leadership meeting was at the exact same time as the patient advisory board meeting in anticipation of that QI meeting happening right after. And so what we found is that we would come up with all these great ideas and then try to sound them off the leadership outside of the meeting and not be able to give them the full context, or kind of have the patient voice directly delivering this message to the leadership, and it wasn't as impactful. And so we made the hard decision to switch the time, and as a result, our patients no longer sit on our clinic-wide QI team, but just on the separate patient advisory board, but have the clinic manager present at those meetings, and we've been able to get a lot more accomplished that way. The other thing I'd suggest to, as far as the mission goes, I think a lot of groups kind of end up shaking out into a kind of a project-driven versus a feedback-driven purpose, and you can certainly combine those, but just making clear expectations up front, because there are a lot of engaged patients who may just have a skill set around team dynamics and getting projects done and anticipate that's the role, and if they're instead being asked to give feedback on things that are happening in the clinic and not really getting their hands dirty with projects, they may be disappointed, or vice versa. All right. So just some common things that Kristen and I have seen emerge. One is that patient-centered language is just hard. Explaining the PCMH to residents is hard, to other doctors is hard, and teaching it to patient advisors is really hard too. We've spent a lot of our initial meetings kind of trying to provide information about clinic workflows, who's who, different roles, what a residency practice means, how scheduling works, a lot of the nuts and bolts about the daily operations of clinic and the people who are working within the clinic walls. The waiting room seems to be certainly not the only focus of the patient advisory board by any means, but it seems to be kind of a safe zone. It's sort of like the patient's place in the clinic. I find that a little sad to say, but I think there is like a bit of patient ownership that naturally happens with the waiting room. And so you may find your patients have a lot of feedback about the waiting room, and that kind of is a nice way to help them feel empowered at those first meetings if you want to make that a topic of discussion. One of the things we found now that we've been operating for a couple of years at this point is that other groups want our patients. They want that patient voice, and they don't have one, a patient advisory board, and so I will get frequent requests from other organizations saying, hey, could we run this by your patient advisory board? I heard you were doing this. And sometimes that's in the interest of the patient advisors, but sometimes it isn't. And I try to keep them, kind of like I said before, from feeling like they're taking on a token patient role. So you kind of have to evaluate exactly where people might be in their process or what their process is that they're seeking feedback on and how it may relate to the group's mission and the patient advisor's interests. And we said this previously, but I'll just reiterate it. It really is a trial and error process. This is a fairly new concept in practice transformation, and it's not well studied. There's no one set of rules about how to make your patient advisory board work well, and even if there were, it probably wouldn't work in every clinic. So don't be afraid to try new topics on the agenda, to experiment with the mission a little bit if it seems like the entire group is leaning a separate way, and just tell the patient advisors that we're kind of in uncharted territory here, and it's going to be a little bit of give and take in getting the organization structure and function down perfectly. So some ideas. So let's say you go through your recruitment, some things you would want to cover at the first meeting. So really talking about how the patient advisory board fits within the vision and the goals of the entire organization, reviewing the bylaws, talking about the structure, and then again, developing the roles and responsibility of members. This, again, think about what resources from the clinic end you have available. If there's limited time from medical staff or providers to commit, then I would definitely advocate for getting a patient advisor willing to send meeting reminders, another to take minutes, etc. One of the things you may consider doing at a first meeting is just introductions in which patients share a little bit of their personal or their family stories about their experience within the healthcare system in general. And the reason for that is when patients come together, the benefit, as we said, is that you get this bouncing around of ideas. You get this group experience that emerges. But when patients and providers and medical staff share their experiences together, what you really develop is this intermediary role where patients become patient advisors. They become more knowledgeable than the average patient about clinic workflows and et cetera, and can speak to kind of some bigger ideas as they interplay with the system itself. And so hearing how people have engaged with the system before can be helpful for sort of taking the first steps towards that more advanced role. You will likely want to review a confidentiality contract and talk about honoring privacy about what you talk about, and for those of you who have received the handouts or who will be receiving the handouts, we do have a sample confidentiality contract in there. And then, like I said before, just some kind of basics about the clinic, who's who, standing meetings, quality improvement processes or projects that are happening, or QI teams that meet regularly and what they do, etc. So after your first meeting, you may be wondering what to talk about next, and these are just some ideas for future agenda suggestions. So we also included a handout on conducting a walkabout, and what that is sort of like a guided tour of the clinic from the front door through to the exam room, to maybe the lab, x-ray, any ancillary services, and then back out the door, and getting patient feedback, or kind of what the patients are viewing or noticing or noting as issues as you physically walk through the building. Another idea would be to do an exercise in which advisors envision their ideal experience. I've seen it where you break into groups of 3, and one group is charged with listing the bare minimums that you expect from your clinic, and then the middle group is kind of the delighter, like the things that just are slightly above and beyond. It's nice to have. And then the third group is the extremes, what the truly ideal above and beyond experience would be within a clinic practice. And then those 3 groups kind of report out and kind of share and spark ideas for the leadership that might be listening. The other nice part of it is that if you're not meeting the bare minimums, then you kind of phrased it in a not explicitly negative way, but the leadership is hopefully taking note of that and fixing those things. And then other ways might be including advisors in the assessment of the clinic practice, and then also reviewing patient survey data, getting kind of that group dynamic I mentioned as an additional layer to that data, having advisors be involved in restructuring projects or individual QI projects, etc.
I would add to your survey data discussion that we had a practice, as you mentioned, that just gives a whole nother layer to survey data. One of my clinics had surveyed all patients for about 2 weeks on accessibility and communication, and they'd been getting a lot of gripes from their patients about the waiting times in the waiting room. And when the survey came back, the results were just great. People kept giving them great reviews for their wait time, and they just couldn't figure out what was going on. Why are patients complaining when we do the survey and they're telling us it's fine? And so it was a great opportunity to take this survey data to the Patient Advisory Council and say, can you help us understand this and why this might be happening? And their feedback was, well, we expect to have to wait. If we call and we want an appointment, you get us in every single day. We don't have to wait. We get in that day. So we're okay with waiting, so that doesn't bother us. So they were kind of getting these mixed messages, but at least it gave them another group to turn to try to explain some of the information they were getting from the survey data.
We've had a lot of success having our patients help edit different documents and turn it into patient-centered language. I've been surprised, even if you produce something at a 5th grade reading level, it still can infer kind of not the connotations you were expecting, and the patients will bring that to your attention. So one specific example of that is we revised our new patient paperwork by having the PAC go through our old patient paperwork and make changes to that. We also had a specific QI project that involved giving patients with diabetes a mini patient-held mini record of their recommended diabetes services. And so they actually changed the entire name of that project. And so we were really thankful we had got them involved up at the get-go because they made a lot of language changes before we were ready to launch that project and before we printed. Our patients also created a newsletter which sat in the waiting room, and then we were able to put together a resource center in the corner of the waiting room with some general disease-specific information, end-of-life information that is available for patients to peruse and pick up that was created by our patient advisors. Just some examples. And then if you really want to keep going with this, some ideas for cranking it up a little bit. One would be ways to involve the patient advisors and their family members outside of the PAC meeting. So maybe as members of QI teams, serving as community health educators, serving as advisors or giving feedback on research projects both within the clinic or at the community level. And then kind of increasing the amount that advisors perform the sustaining measures of the board, the recruitment, the agenda setting, the facilitation, et cetera. And then a number of advisory boards have taken the lead on clinic awareness projects. I know of a Denver-based patient advisory board that made a movie that played in the waiting room that went over the roles of the staff members, residents, attendings with that patients may interface with within their clinic visit. Okay, so some benefits we've seen. Like I said, the language changes are, even if you feel like you can have a very good sense of patient-centered language, I feel like it's always a bit surprising, the things that I fail to think of that our patient advisors bring forth as suggestions for changes on our paperwork or projects, et cetera. You'll also notice over time, as long as you're providing that feedback, hey, the PAC said this about this QI project, the PAC said that about that QI project, et cetera, there eventually occurs a culture change around seeking the patient voice because people are more aware of the advisory board's presence and benefits, and so it becomes more routine to start the project and then automatically question where you could possibly get the patient involved in that process. And then we talked about this before. Another huge benefit is really just that that collaborative role that develops of medical staff and providers and patients all being in the same room together addressing what frequently is mutual concerns. Kristen, did you have any other things to add with that?
I don't think so.
Okay, so moving on here, we're almost at the end if people are going to have questions. We just wanted to give you some resources. So the Institute for Patient and Family Centered Care, IPFCC, has a lot of great tools on their website. And so here are some websites you may want to check out. I'll just pause here for maybe another 10 seconds, and then we'll move on. Okay, and then I just wanted to make everyone aware of what was in the handouts email. So we were hoping this could be a sort of toolkit to get you going. So there's a confidentiality, there's an example of a confidentiality contract. There's example bylaws, I think that they're titled protocol. And then there's a document, who's who in clinic, going over the roles of different medical staff and different types of providers in the clinic. We did include an example of recurring meetings that occur within the clinic, and then a couple handouts are focused on some of those agenda suggestions we talked about. One's the magic wand exercise, which is sort of that exercise to get at suggestions for the ideal state, and then another is how to conduct a walkthrough, which we spelled wrong, I'm sorry about that. so goes over how you can do that door to door, walking through the clinic, getting patient feedback. And then that is the conclusion of our content. So we'd love to hear if any questions have been coming in.
Great. Thank you both so much for this presentation. So as a reminder, you can ask questions through the little questions text box. Just type your question in, or if you'd like to ask your question verbally, just click that little hand that looks like it's waving on the GoToWebinar control panel, and I will unmute you. Okay, can you speak a bit to how to engage maybe clinic level leadership if a patient advisory council is something practitioners and staff want to start, and getting the buy-in from your administration?
Kristen, do you have any personal stories?
Go ahead, and I'll follow you.
Mm-hmm. I feel like I was kind of in a lucky position. Our PAC actually was initially was started as by our former clinic manager. However, that being said, our clinic managers, that manager left, and another one came in shortly upon starting the patient advisory board. And so, to be honest, how it presented is that a resident, a CTA, an MA, and a nurse were getting an hour and a half taken out of their schedules each week or each month to attend this meeting, and we weren't seeing a lot of outcomes. And so, so people were starting to ask why. And so we said, because we don't have a pipeline to you, there's a lot of good stuff happening here, I promise. And if you start coming to this meeting, I guarantee you'll see it. And so, kind of by people wanting to know what was going on, they bought into at least seeing what was going on, and once they started attending, they were on board.
And I had one practice that the idea really did come from a mid-level and their care manager. And so they went ahead and they had the support, but they didn't really have active engagement, I wouldn't say, from the leadership. So they had the support to get it started, and they went ahead and they found they recruited the members and started the meetings, set the agendas and everything. And what they started to do was similar to what Amy was just suggesting, and they rotated and they asked each provider to come from one quarter to the next. So they had 4 providers, and each one just came, they started with one and they rotated through. And so each of them was able to slowly be part of the process and start to see what was coming of these meetings. And the provider who was the least engaged ended up being the last to come. And I think that actually ended up working out well for them, because they had a lot of things going by the time he attended. And he now, I think, attends regularly because he really enjoyed the feedback and the discussion that was happening during those meetings. So I think if you can get the support and you can start the process, once they can see the outcome starting to come, that really does make a difference.
Mm-hmm. And the only thing, too, I'd say is in building the argument is it really is not, I mean, we're lucky in our clinic that a number of people in different roles, time gets protected, but we don't have food at each meeting. Our patients volunteer their time. It really is, with the exception of those people's block times, $0 otherwise. And so it's a pretty minimal investment, at least on our end, for pretty optimal results.
Great, thank you. Any other questions from our participants? Stay on for a few more minutes to see if anything else trickles in. Okay, well, thank you so much for the great overview and tips on how to get a patient advisory council started and some tools to implement. And thank you to our participants for joining us today. Have a good afternoon.
Thanks, Emma. Thanks for listening, guys.
Bye.
Bye.
Bye-bye.